Hello, and welcome to the Body Fusion Therapy Podcast. I'm your host, Dr. Heather Demercy. On today's episode, we're going to be talking about infertility and how manual physical therapy can help. Let's start off with some facts, though. In the U.S., about 12% of women are having fertility difficulties. That breaks down to about 6.7 million people each year that are struggling with conceiving. The rule of thumb is actually a 30-30-30-10. Of the cases of infertility, about 30% are from the women, 30% are from the men, 30% are from both the men and women, and 10% is unknown. There's different figures that are out there, but it all kind of shakes down to it's equal between the cause of infertility being a male and female issue. While most times it's blamed on the woman, there really need to be assessment of the males as well. 25% of female infertility is linked to problems with ovulation, and your chances of getting pregnant with each ovulation cycle are only about 25 to 30%. When you start to have medical intervention, things can get really costly. The average cost of IVF in the U.S. is around $20,000 and is often not covered by insurance. Egg retrievals alone cost about $10,000, and that's not even including the medications and storage costs. Physical therapy isn't usually part of this gold standard when it comes to infertility, but I'm hoping that starts to change. In today's episode, I'm going to be covering what are the assessment questions that I ask when someone comes in for infertility treatments, what is the treatment that I give for men, treatment for women, including more of the natural pregnancy route, and then also when medical intervention needs to be included, and what other organs and structures that need to be assessed and treated that you wouldn't necessarily think are associated with reproductive issues. Let's start off with the questions. First thing that always needs to be asked is, have both partners been assessed? As I've just said from the 30-30-30-10 rule, it's an equal split between the cause of infertility being from the man's side and from the woman's side. So I need to know if they both have been assessed. If both partners have been assessed, I want to know what tests have been completed. What are the blood test results? Has there been any imaging done? What information can they give to me that will help me further how I'm going to be treating them and what I need to be assessing on my end? When we're looking at specific questions for the men, let's start with urination questions. One of the first questions that needs to be asked is if the man is getting up to urinate at night. Now, for some reason, everyone thinks that it's just a normal progression. That's what should happen is as the man gets older, he's going to have to wake up and go to the bathroom. That's not efficiency, though. They shouldn't have to get up to urinate in the middle of the night. Your bladder should be able to hold the entire time. So what that tells me is that there is a dysfunction that's happening within the pelvic girdle. This could be it could be the bladder, it could be the prostate, it could be the pelvic floor muscles, whatever it is, something's not right and needs to be assessed and treated. I also want to know what is the strength of their stream of urination and has it changed over time. It should be a strong stream of urine and it shouldn't be any decrease. But I want to know what a full bladder is like for them. So it should be in the most efficient state about 15 to 17 seconds. Now that's 15 to 17 Mississippi seconds, not 1, 2, 3, 4, 5, 6, 7. So that is what a full bladder should be for a male. So if it's not that, then that shows that there's restrictions and adhesions within the pelvic girdle that need to be assessed and treated. When talking about intercourse, I want to know how their erection is. Are they able to get erected easily? And if there's any pain with intercourse. And where is the pain with intercourse? And at what point during intercourse does the pain occur? This will also tell me what is going on with blood flow and with adhesions that could be occurring down in the pelvic girdle. Lastly, for men, I want to ask about lifestyle. It's really important for a man and woman to exercise to help with fertility because you are just in a better state of health, you have better blood flow, but actually exercising too much can be a hindrance for male fertility. So I want to know what sort of exercise routine they have and what type of exercise they're doing. You also need to know about alcohol and drug use as well. For the female-specific questions, I start off first asking about their menstrual cycle. I want to know if they have any pain at all during their periods. Pain is normal in the sense that a lot of women have it, but it's not efficient. You shouldn't have any pain on your period or any cramping. So I want to know if there is any pain, and then where is the pain located? Is it in the front, in their lower abdomen, or is it in their back? That tells me a lot about what adhesions might be around that uterus that is getting pulled on as their uterus is contracting to shed its lining during the period. I also want to know what's the average length of their cycle and how many days of bleeding do they have. With the blood itself, I want to ask them about the texture and the color of the blood. The blood shouldn't be very clumpy, nor should it be a really dark color. I want to see that it's a little bit more liquidy and that it has a more bright red color. That's showing that it's kind of healthy new tissue and lining that's being shed rather than really old tissue. I'm also asking if they have headaches with their ovulation cycles or with their menstruation. Women have a piece of fascia that goes from each ovary and connects to the base of the skull. So now as the uterus is contracting to shed its lining during menstruation, it can pull on this piece of fascia and actually cause these headaches. Many women think that it's more hormonal based, but it actually can be a structural issue. The same thing can occur during ovulation, but it's usually one side over the other that they'll get the headache going. So I want to know if they're having headaches with either ovulation cycle or with their menstruation cycle. Finally, I ask if they have any bowel changes when they have their period. This can be hormonally caused, but also it can be a structural issue. The rectum is sitting right behind the uterus. And if there are adhesions from the uterus back to the sacrum, like back to the back of the pelvis or onto the rectum, it can affect how the bowels move. It can either make them more constipated or make them more loose stools, closer to diarrhea. All of these questions are kind of giving me a better idea of what position the uterus can be in. Next, I'll ask questions about intercourse. I want to know if they have pain with intercourse and if they do, when that pain occurs. It's very different causes from pain from initiation of intercourse to pain right after climax. The information of when they get pain, if they do get pain with intercourse, is helping me figure out in my assessment where I need to be going to address the issue. If the pain is towards the beginning of intercourse, it could just be an alignment issue of the uterus that's affecting the vaginal canal. It could be an issue with lubrication. But if the pain is at climax and after climax, it could actually be a pelvic congestion issue or too much fluid that's being left in the pelvis that isn't able to evacuate. So you can't just simply ask, do you have pain with intercourse, yes or no? You need to know more about that. And as the patient or as a woman dealing with infertility, you need to explain that a little bit more as to when you get pain with intercourse. I also want to know if they have certain positions of intercourse that they avoid or ones that they prefer. This helps to find out if there is a position of the uterus. So if they prefer to be on their back and don't want to be on their front, that's going to tell me that that uterus most likely is positioned too far back, almost like a tilted uterus. Or if they prefer to be on their front, that also shows that maybe their uterus is stuck too far forward and can't fall back. Both are issues with their infertility. So I want to know if there's positions that they want to avoid or not. I also ask about urination because the rectum is sitting behind the uterus, but the bladder is sitting in front of it. So I also want to know what their urination stream count is when they feel like they have a full bladder. Now, women's urination stream is a little bit less. It's 13 to 15 seconds or 13 to 15 Mississippis rather than the male's 15 to 17. And this is because men don't have a uterus that's in the way while women do. So the bladder isn't able to fully expand. So you do have a little bit less room in there. I also want to know if they're getting up to urinate at night. All of these are showing me that if they have issues with their pelvic floor and adhesions that could be occurring within those organs. When getting to the treatment, both men and women need to be assessed for pelvic alignment issues. The pelvis alignment or malalignment of the pelvis is going to have an effect on fertility for both sides. Now, for women, it is interesting. I did have a patient once who came in with imaging of her uterus, ovaries, and fallopian tubes. And from that image, you could see that one side of the uterus was elevated and also kind of tilted backwards. And when I got up and to assess her for her pelvic alignment, her pelvis is the exact same thing. The pelvis on that right side was elevated and rotated backwards. And that's exactly how it looked on her imaging of her reproductive organs. So it's not crazy to think that whatever is happening with the pelvis is going to be mimicked then within the reproductive organ. So it's really important that pelvic alignment is assessed and get into that neutral position so that the organs inside should also be in a more neutral position to help with fertility. The alignment issues of the pelvis can also affect the pelvic floor. Now, that pelvic floor, you can't have too much tension on there because that's going to be affecting both men and women in terms of their ability for men to have their ejaculation and the effect it's going to have on their prostate. And for women, the opening of the vaginal canal and position of the cervix will also be affected if the pelvic floor muscles are too tensioned from being in this malalignment position. Both men and women need to have their bladders assessed as well. They need to be able to move up, back, down, right, left, in all directions. There needs to be a healthy mobility of the bladder. For men specifically, the bladder needs to be able to move away from the prostate. So the prostate is sitting underneath the bladder. So you need to be able to move that bladder up and away from the prostate so the prostate has room. One of the prostate's main jobs is to actually inject fluid to then kind of create that semen to put it in through the urethra. So you need to have good mobility of that bladder off of the prostate for the prostate to be able to move. For women, the uterus needs to be able to move off of the bladder. So you need to be assessing what sort of uterine motions can occur around the mobility of the bladder, make sure that the two are independent of each other. Regardless of gender, the pelvic alignment and the bladder mobility need to be assessed for both males and females. When treating males for infertility, you also need to be looking at hip flexion mobility, so the ability for the hip to bend. This is important because of the spermatic cord. The spermatic cord is the vessel that takes the sperm from the testicles and puts it into by the prostate to mix with the other fluids to become semen. So it's not crazy to think that if the hip can't flex easily, if they're getting a pinching through the front of their hip when they're bending through there, that is also impacting the spermatic cord. So you want to free up any sort of hip flexion mobility issues. With that comes up with clearing of the groin and the inguinal ligament, just freeing up all the tissue so there's no impact on that spermatic cord. Men also need to have their prostates treated. The prostate needs to be able to move in all different directions and have good mobility. Because again, the point of the prostate is to inject other fluids to then create the semen. So it needs to have good mobility in all different directions. But first you have to treat the bladder before you can really get to the prostate effectively. When treating for female infertility, the first thing that needs to be assessed is the position of the reproductive organs. What is the position of the ovaries, fallopian tubes, and uterus? It's really important that there's a neutral position that will allow for the egg to go from the ovary into the fallopian tube and down into the uterus for implantation. There was a study done with women that suffer from tubal occlusion or a blockage of the fallopian tube. 28 women that either had one or both tubes occluded were given about 20 hours of manual PT. At the end of this, 17 of them had one or more openings. And this shows efficacy of manual therapy in the treatment of infertility, especially if it's tubal occlusion. It's a non-invasive treatment rather than having an invasive medical procedure, and it can help freeing up the fallopian tubes. The fallopian tubes can almost have like a kink from the outside if there's a piece of fascia that's holding and pulling up on the tube. And this will lead to a blockage of that fallopian tube and not allow for the egg to travel down for implantation. The uterus is held within the pelvic girdle through a series of ligaments, kind of a scaffolding to hold it up. The uterus isn't just thrown in there and kind of smashed between multiple organs. It does have a structure to keep it upright. So these ligaments need to be assessed for mobility and positioning. The information that you get from the assessment in terms of pain with intercourse or pain with their menstrual cycles will be a great way to then also validate what is felt through the manual assessment of the uterus and the uterine position. So you can mobilize the ligaments of the uterus to get it sitting into that more efficient position to allow for proper implantation of the egg. Manual physical therapy can also help with women undergoing egg retrievals. This is an area that's very rarely discussed, and honestly, I couldn't find any research articles on this. So I'm going to talk about more from what I've experienced with my own patients. And I'll give you a couple examples of those. So the egg retrievals, remember, cost about $10,000. So why not try having physical therapy to help so you get the most out of it? The goal of manual therapy with an egg retrieval is to clear up the fascia around the ovaries so they're allowed to expand fully. The hormones that a woman is given to try to increase the number of follicles or potential eggs is going to make the ovaries expand much larger than they would during a normal cycle of ovulation. And so if there's fascia around the ovary that's limiting its ability to expand, the follicles won't be able to grow as much, and you will see a limitation in the number of follicles that are able to be retrieved. Now, I have two examples here that I can talk about. One was a 42-year-old woman who got married later in life and was worried about infertility. And so she wanted to start to freeze her eggs just in case. She had already undergone one egg retrieval and received no eggs. When I saw her, the first thing I treated her was for actually dysfunction of the tailbone. The tailbone, or what we call the coccyx, is going to affect the alignment of the pelvis. And you can remember from the first thing that we talked about in terms of treatment is that everyone should have their pelvic alignment assessed because this will affect what's happening within the pelvic cavity itself. So I treated her coccyx, and then she also said that she had very painful periods. So I worked on mobility of all the different uterine ligaments and freeing up the fascia around the ovaries. She had a lot of restriction around both ovaries, and there was a lot of tension felt in through the whole pelvic girdle area. I worked on her for about 2 sessions, and then she went and had her next egg retrieval, and she was able to get 3 healthy eggs. So at this point, she stopped, and she was able to later on, when she was ready in about a year, have a successful implantation using IVF. So this is a woman who had no eggs whatsoever on the first retrieval, and after working on her for just 2 sessions, she was able to have 3 eggs healthy. Another example of a woman I was able to help was a 38-year-old female that had previously undergone 3 egg retrievals. That resulted in about 13 eggs, but none of them were viable. So even though there are eggs that are able to be retrieved during these procedures, doesn't mean that all of them are actually genetically viable to be inseminated and then implanted. So she had gotten 13 eggs, but none of them were viable. And all the eggs had come from her right ovary. No follicles were found forming in the left ovary at all during these 3 implantations. Now, she sadly had a history of physical abuse as a child, where she remembers getting kicked repeatedly in the lower abdomen. So I worked on her for about a total of 6 sessions, clearing up scar tissue in the pelvic girdle and trying to improve blood flow into the pelvis. On her next and ended up being her last egg retrieval, she had 17 eggs. 11 of them came from the left ovary, and 12 of the eggs were viable. So she had a massive increase in the number of eggs just by freeing up all the scar tissue and fascia around that left ovary. Now she has options, and now she'll be able to get pregnant, hopefully, when she's ready to. So this is an area of physical therapy that I think needs to be out there more as the standard of care. And because egg retrievals are so expensive and all the hormones that are being pumped through the body, why not try to set yourself up for the best round of infertility treatment as possible with having some manual physical therapy done just to improve the fascia and the blood flow around the area? Now, I mentioned that there's other organs that can be assessed that aren't directly related to reproductive health, but actually have a huge impact on that. So those 2 organs that need to be assessed are the liver and the small intestines. The liver actually has a massive amount of blood vessels that go down into the pelvic area and down into the abdomen. When women tell me that they complain of kind of pelvic congestion-like symptoms, which could be an always feeling of fullness in through their pelvic floor, and also if they have pain at climax, that's usually a sign of this pelvic congestion or blood flow issues. Liver can be a big component of that. So the mobility of the liver needs to be improved to help improve the blood flow in and around the pelvic girdle. The liver also has over 300 jobs, and some of those are hormone regulation and hormone production. So you want to have a healthy liver to help with fertility treatments as well. Assessment of the small intestines is also really important because of what sits behind them. The major blood flow in and out of the lower body is right behind the small intestines in the form of the abdominal aorta and the inferior vena cava. So you have restrictions of that small intestine. It will actually limit the blood flow going into the pelvic girdle as well. So both the liver and the small intestine mobilization is to help with getting good blood flow down into the reproductive organs for both men and women. So you need to be able to mobilize both of these areas just to improve overall health. I hope you can see from this episode that there is a lot that can be assessed and treated with manual physical therapy. It should become the standard of care for women and couples that are dealing with infertility. I really hope that the infertility doctors start to see the efficacy of these treatments and how it will benefit their patients from having less medical interventions. It can lower the cost of fertility treatments because you don't have to go through as many rounds. And it's also, more importantly, it's going to decrease the amount of hormones that are going through the woman and the medications that they have to take to be able to have a family. There are many components in treating infertility, and the purpose of this podcast was to shed the light on how physical therapy can be part of the treatment process. But it in no way means that this is the only answer. I see the best outcomes when it is a multidisciplinary approach to infertility, and that includes both infertility doctors, your OBGYNs, psychologists and psychiatrists as needed, meditation, stress reduction, and then also the physical therapy component as well. So it needs to be coming all together to have a well-rounded treatment to help these families. Thank you for tuning in to this episode of the Body Fusion Therapy Podcast. Please share it with your friends and family, as well as leave a review if you liked what you heard today. We're looking forward to continuing this journey of looking at the body. Tune in next time.